Very good evening to everybody present here. On behalf of Team Professional Health, we all welcome you to the live session on the diabetic kidney disease. Today, we have with us one of the most outstanding doctors in field of nephrology. We wholeheartedly welcome Dr. Rajeevalochana ma'am to the session. So to start with a few words about Dr. Rajeevalochana is a consultant in Department of Nephrology, Institute of Kidney and Organ Transplantation at the Madras Medical Mission. Doctor specializes in treatment of patients with any spectrum of kidney disease that includes dialysis, transplantation, acute kidney injury, glomerular diseases, etc. Ma'am is also an ASC affiliated multi-organ transplant fellow. In research career, Ma'am is also glorious. She has published many research papers in popular journals. It's a pride to have Ma'am with us this evening. A very good evening, Ma'am.
Thank you, Sriram, for that kind introduction, and thanks, guys, for having me. Thanks, Sriram, for kind of suggesting this, talk. I think diabetes should be learned at a MBBS level in order to treat it properly once you guys finish your internship and subsequently specialize much more. So, if all of you are ready, we can start. I think, Karthik.
Yes, ma'am. Without any further delay, we can start today's session. Ma'am,
Yeah.
so the first question is from the basics. So could you please explain to our viewers about chronic kidney disease and its probable causes?
Okay. So, before I go to my talk, I just want to tell you, I have kind of gone very basic because I want all of you to understand what exactly is chronic kidney disease, how diabetes is important, and how it fits into that picture. And once you start treating people, actually, what exactly you have to do when you see a diabetic. Slowly, you will have so many diabetics in your own family, I'm sure. So,
Yes, ma'am.
I think it's fairly very important to know what exactly you have to do to detect diabetic kidney disease. So, hopefully, I'll be able to kind of convey it in a best possible manner. Now, what we'll do is, can we have any alternate questions towards the end so that we finish the whole thing and then we can have the questions towards the end, I think, right?
Yes, ma'am. Sure.
Is it okay? Okay. Can you see my slides?
Ma'am, yes, ma'am. It is visible.
Right. Okay. So, what is chronic kidney disease? Basically, these are the abnormalities of any structure or function in the kidney. So, the way the kidney looks, if the structure is abnormal or if the kidney is not functioning properly, even any of these two things are present for more than 3 months, which is causing issues, then we call it as chronic kidney disease. Now, for example, so basically the cutoff is 3 months. So hopefully I'm clear. So any abnormalities of kidney structure or function which is there for more than 3 months. Now, for example, either the glomerular filtration rate, which we'll be going into much detail, is less than 60 ml per minute per 1.73 meters squared for more than 3 months, or the patient is having, say, albuminuria or proteinuria, which is significant for more than 3 months, or some people may be born with just one kidney and that itself is a structural issue and it is obviously present for more than 3 months. So, somebody having polycystic kidneys, which is again a structural abnormality, again falls into the group of chronic kidney disease. Now, why do we, somebody who has a good kidney function and somebody who has a good kidney function and we were saying, okay, they have a mild abnormality in the structure. Why should I call it chronic kidney disease? Well, it's very important to kind of monitor these patients so that we don't give them any unnecessary drugs. We treat their hypertension, etc., properly. So it is important to know this definition. Um, so my next thing is, now what can cause chronic kidney disease? I've highlighted diabetes because it is the number one cause both in India, abroad, as probably the world, followed by hypertension. Like any other disease, chronic diseases, they are modifiable and non-modifiable risk factors. And diabetes, to a large extent, is a modifiable risk factor. Hypertension is one more. History of any acute kidney issues which have occurred in the past, that again makes it a risk factor for kidney disease. Frequent painkiller use, which is called as NSAID, smoking. So all these can be actually stopped, and we can actually prevent the progression of chronic kidney disease. Non-modifiable ones are those which have like autosomal dominant or like a genetic disease which nobody can do anything about other than just monitor. Older people as well as race. For example, African Americans have a slightly higher risk of developing certain kidney diseases. Even Indians, for that matter. For example, there is a disease called as IgA nephropathy, which Indians seem to have a worse prognosis when compared to others. So obviously, we can't change our race. We cannot grow younger, and our family history, again, we don't choose our families, but modifiable, definitely diabetes falls into that category.
Yes, ma'am. Thank you, ma'am. Ma'am, it would be good if you can put it in slideshow mode, ma'am, so that it gets magnified a little better.
Yeah, it is in the slideshow mode.
Okay. Yes. So, ma'am, shall we move on to the next question?
Yeah.
Yes, ma'am. So, ma'am, as you said, kidney is a very important organ in our body. So, is there any specific test to which we can assess the normal functioning of kidney, ma'am?
Well, yes. So, two very important tests to assess the kidney function is one, the blood creatinine, also called as the serum creatinine level, and the other is your urine protein leakage. And of course, anybody with kidney disease should have a scan, ultrasound of the kidney done to look at the structure of the kidney. Now, one of the most important things which ultimately lead us to measuring or rather estimating the glomerular filtration rate is the serum creatinine. Now, so basically anything above
Ma'am,
60
the
mils
slides
per.
are not moving, ma'am. Like it's still in the
Yeah,
discuss. Sorry.
I know. I have not moved. I'm still talking.
Okay, sorry.
Yeah, so GFR more than 60 ml per minute. So always remember the glomerular filtration rate above 60 ml per minute is fairly normal. Between 15 to 60, that is 15 ml per minute per 1.73 meter squared, so 60 ml per minute per 1.73 meter squared is where you basically have significant kidney disease. And then there's a lot you can do in this bracket in order to prevent the progression to less than 15, where basically you say that somebody has kidney failure. So the recent consensus is that we don't use the word failure in anybody. Rather, we say that they have reached basically a stage where they require renal replacement therapy. Now, most like I don't know how many of you would have looked at your relatives' blood tests. There are many labs which give the glomerular filtration rate, and many times we get panic calls saying that there is some level which is given here. Is that okay? Now, again, a GFR of 60 or more is fairly within the normal range. A GFR below 60 may mean kidney disease, again, has to be slightly interpreted with caution. And a GFR of less than 15 is obviously a red flag as shown in the picture, and it has to be dealt with fairly seriously by a nephrologist. Now, what is this GFR? So, it's basically so how many? So generally we are born with a finite number of nephrons, exactly like the way we have neurons. So glomerular filtration rate. So we have around 1 million nephrons in both our kidneys, which is equal to the sum of the. So basically, this GFR what we are measuring is equal to the sum of the filtration rate in all of those functioning nephrons. Now we don't know, like we generally have an idea that somebody, a normal individual born with a normal birth weight, will be having around 1 million nephrons. Some of us may be having slightly less, and as we age, the number of functioning nephrons slowly come down. Now, GFR measurement is extremely kind of important in most of the settings, though it is actually not measured. It's very important because the kidney not only removes all the waste products, it removes salt, right? Filters it's important in blood pressure, it's important in water balance, it's important in soil hypertension, it's very important in so many hormones like vitamin D, erythropoietin, etc., etc. So and it's very important for drug elimination. So any drug you give, most of them are eliminated by the kidney. So it's very important to know somebody's GFR before you start prescribing drugs, because we need to correct it for the GFR. So an estimation of the GFR using the serum creatinine level only gives us a rough measure of the number of functioning nephrons. Now, hopefully all of you have finished your first year of MBBS. So there are the actual measured GFR, also called as MGFR. The gold standard for this is something called as the inulin test. Now, have you heard of it?
Excuse me, ma'am.
Yeah.
Ma'am, sorry for the interruption, ma'am. Are you still moving the slides, ma'am?
No, no. If I'm moving the slides, I'll move it. Don't worry.
Because it's still showing the second slide only, ma'am.
What is the GFR it is showing?
It is not moving. We are only able to see your screen. The where there is a second slide, diabetes and non-modifiable. That one, that slide, ma'am.
Okay, 1 minute.
Yes, ma'am. Now it is moving. So you have to every time click at the slide when you move to the next slide, ma'am.
I am doing that. I think it just got stuck there.
Yes. Now it is fine. Now it is in the GFR bar diagram.
Okay, 1 second. Now can you see?
It is in the GFR diagram, ma'am.
Yeah, now explaining GFR is seen.
No, ma'am. Yeah. Now it is changing. Now it is in explaining GFR.
Okay.
Ma'am, but the thing is, it is not in the full slideshow, ma'am.
Yeah, when it's in the slideshow, it is not sharing this one. Are you able
Yes,
to see
yes,
it actually?
yes, ma'am. We are able to see it to an extent.
Yes, ma'am.
Can you see now?
Explaining GFR. It is in
Yeah.
that slide,
Yes,
ma'am.
ma'am. Yes, ma'am. We can see.
Yes.
What is this?
Sorry
What is
for
the
the interruption.
GFR? Now, what is the slide you are seeing?
Ma'am, explaining GFR.
Okay, well then I have to go back to this so that because it's
Yeah.
not going with the slideshow actually.
Yes, ma'am. Not an issue. When it is not in slideshow, they can zoom in their screens and see the text, ma'am. So
Okay,
that
then
won't be a problem.
so let me just go back to what is GFR. This can you see now?
Yes, ma'am.
Yes, ma'am.
Okay. So basically, as I've already explained, the GFR is basically equal to the sum of the filtration rates in all of the functioning nephrons. So basically, we assume that most of us are blessed with 1 million nephrons and are fairly kind of finite. What you mean by finite is like the neurons. You cannot develop more nephrons. It's not like the liver where you cut a piece of the liver and actually grows back. The kidney is not like that. Once a part of it is destroyed, it is destroyed. No new nephrons develop. Only the existing functioning nephrons will continue working. So, and it's extremely important to measure this glomerular filtration rate. Now, is everyone in this particular forum after finished their first year of MBBS?
Yes, ma'am. Most of them have finished, ma'am.
Right. Okay. So you guys would have read in physiology about inulin. So basically, this is the gold standard to measure glomerular filtration rate. So, because inulin is basically a very nice substance because it is neither absorbed by the kidney nor is it secreted in the kidney, nor it is freely filtered through the glomerulus and it is completely excreted without much of a extraneous influence on it. So, inulin is what is used to measure the GFR, also called as MGFR. However, to do an inulin test is extremely cumbersome in a normal life. So we need some sort of a marker in order to measure or rather estimate the GFR, also called as eGFR. So what has currently we all use is something called as serum creatinine. Now creatinine is a base product of muscle metabolism and it only gives us a rough measure of the number of functioning nephrons. So most of the GFRs which you are seeing in a lab setting or even in your hospitals or even in your clinics is basically the estimated GFR. Can you see my next slide? What is the GFR?
Yes, ma'am.
Yeah. So as all of you know, I'm sure the cardiac output is around 5 to 6 liters per minute, of which the 20% of the cardiac output goes to the kidneys. So that is around 1.2 liters per minute. I'm just approximately telling you. Now, the plasma forms around 50% of the blood volume, which is around 600. So 1.2 divided by 2 is 600 ml per minute. And the filtration fraction, which is present in the glomerulus, is around 20%. So 20% of 600 is around 120 ml per minute. This is what is basically the glomerular filtration rate. Now, but when we use the creatinine to measure this, we are not exactly measuring the GFR. We are only assuming that the estimate of this GFR is approximately this much. Therefore, the serum creatinine based equation should be slightly interpreted with caution. You don't have to go that much into detail. Please remember only two things. There is a measured GFR and there is an estimated GFR. Measured GFR is a gold standard where we use inulin. Hopefully, you guys have read about that in physiology. And the estimated GFR is what we actually see with using serum creatinine. Now, coming to estimating. So, eGFR only estimates the measured GFR, as I've already told you. So, it gives us a 30% plus minus 30% of the GFR in approximately 85% of the people. What it means, what the sentence means is, now if I say that somebody is like, for example, my GFR is 90, that means that it can be plus minus 30%. So, that much variability can be there when we use serum creatinine as a measure. Now, two main equations you have to remember is one is the MDRD and the other equation is the CKD-EPI, also called as Chronic Kidney Disease Epidemiology Consortium equation. These are the two equations we currently use as nephrologists to estimate the GFR based on serum creatinine levels. Now, results can be fairly inaccurate, especially if on a daily basis the creatinine changes. For example, someone has a snake bite that the kidney is affected, then daily there will be a change in the creatinine. So, this GFR may not be a steady value. If the patient is too thin or with no muscle mass, if somebody has a liver disease, if somebody is extremely malnourished, if somebody is extremely obese, if somebody is predominantly a non-vegetarian, all these makes a difference to their serum creatinine level. So a small petite lady, her creatinine should not be compared to a bodybuilder's creatinine. Medication, there are so many medications that interfere with the measurement of the serum creatinine. There are a lot of you, I'm sure, who go and gym and use creatinine supplements. All of this make a difference to the serum creatinine. So even if you get a question on estimated GFR, please make sure you write about the fallacies of the creatinine-based estimations of kidney function. So estimating GFRs therefore are less reliable as at a very high GFR. You have to remember as we turn 35 to 40, the kidney function declines slowly. While there is an association between decreased GFR and morbidity, even in the elderly, This does not mean anything unless it is ratified by a nephrologist saying, yes, this actually makes a difference. Okay. So basically, this is a small table showing you how as we age, like between 20 to 29, which most of you are, your GFR should be fairly good if your muscle mass is good. But after the age of 40, it slowly starts coming down. And by after 70 years of age, even a GFR of around 75 is fairly normal for that age group. Am I clear till now?
Yes, ma'am, you're very clear.
So basically, all our professional bodies, we have something called as KD Go. So we have many guidelines which have been told to us. So these guidelines tell us a creatinine-based equation, mainly the CKD epi equation, should be used in order to calculate EGFR. It has the least amount of errors. Now, I have given a link to the GFR calculators, which are lot of them are available online. There are many apps online. The National Kidney Foundation, that is NKF, itself has a free app which you people can download and keep kind of putting this creatinine and the age and etc. and seeing how this GFR keeps changing. Okay. So now the significant other. So creatinine or GFR alone is not enough to tell us that somebody has kidney disease. The significant other, it has to be married to albumin or rather the protein in order to see whether it is getting. So inside a healthy kidney, generally albumin is not leaked into the urine. The brown dots are actually the albumin. Whereas in a damaged kidney, so the blood goes to the afferent arteriole and gets filtered at the capillary level in the glomerulus. So what happens is all these filters become very very leaky and start leaking protein into the urine, and this is again a measure of a unhealthy kidney. I'm not going to delve too much into details on albumin because I think one of my colleagues will be speaking about it later. But please remember that an abnormal urine albumin level is a marker for glomerular disease, including diabetes. It is a marker for so many things. That is a marker of cardiovascular disease, a generalized issue with the endothelial dysfunction, and it has significant associations with mortality. What mortality means is death. Okay. Now, basically, a damaged kidney allows more albumin to cross the filtration barrier into the urine. There is increased glomerular permeability, which allows albumin and other proteins to cross the glomerulus into the urine, and higher levels of protein, which exceed. So, the tubule to some extent can reabsorb that protein, but even that capacity is exceeded. And slowly, this protein leak will cause further and further and further damage to the kidney and lead to more loss of nephrons, which cannot be retrieved back. So basically, at the end of these 6 or 7 slides, what I want you to remember is serum creatinine is used to measure to actually calculate the estimated glomerular filtration rate. Glomerular, and basically it gives us a rough idea on how the kidney is working. Anything below 60 should alert somebody saying that, oh, this patient may have kidney disease. But of course, when you do see such a value, it is important to always combine it with a urine test. A urine test is the stethoscope of a nephrologist. Please remember that a urine analysis is extremely important in any person who sees a patient for any kidney related issue. And it is a big sort of a microscope. We see so many things in the urine. I will not delve into it because that is not today's topic. But it's very important to get a basic urine analysis and, if possible, a urinary albumin to see whether we have leakage of protein in the urine. Yeah. Okay. Can we go on to the next question?
Yes, ma'am. Thank you so much for such a clear explanation and for the recalling also, ma'am. Ma'am, so as we were speaking about the kidney diseases, we all very well know that India is hub of diabetes. So how can a diabetic get affected, ma'am? Like, what is the influence of diabetes on kidney?
Well, So before that, I just want to tell you that based on glomerular filtration rate, we kind of classify the stages of kidney disease into stage 1, where the kidney may be normal, or we may just have some structural damage, but not no much of a functional damage, and the GFR is more than 90. Then the kidney damage with a mild decrease, that is around 60 to 89, then 30 to 59, 15 to 29, and less than 15. So less than 15 is where the whole concept of dialysis may be needed. Now coming to this, it may be a little difficult for you to understand this, but basically what we have to do is whenever we see somebody where we have a doubt of any kidney disease, both a glomerular filtration rate as well as a urine albumin has to be measured, and it has to be interpreted together. So somebody with even a normal GFR but is leaking protein still falls into a high risk category. And if both are present, they go into the zone red. So basically, both a decreased glomerular filtration rate with an albumin leak in the urine basically indicates kidney disease to a large extent. Now, coming to diabetes as such, now, as all of you probably know, diabetes is of two types. One is the type 1, which is basically that somebody does not produce any insulin, to make it simple for you. Type 2 diabetes, which is generally seen in the older age group. So basically, the type 2 diabetes is the person was fairly normal, was producing insulin, but now the organs are responding less to that insulin, or they have something called as insulin resistance. There are other types of diabetes, like for example, secondary to Cushing syndrome and secondary to other endocrine disorders. And then you have the gestational diabetes mellitus, which basically develops during pregnancy. We will be mainly concentrating on type 1 and type 2 diabetes, and basically how the kidney disease develops in this group of patients. So, what happens is the glucose is actually permeable through the glomerulus. Now, what happens is in the proximal tubule, you have something called as the sodium glucose transporter, which is present, which basically reabsorbs the glucose and does not allow glucose to leak into the urine. In type 2 or even type 1 diabetes, the kidney's maximum glucose reabsorption threshold is exceeded, resulting in glycosuria. And this probably kickstarts a whole lot of events which lead to diabetic kidney disease. So similarly, what happens is, this is basically, if you can see this figure, the green part is something called as a podocyte, which is basically food processes around the nephron. The white part is your capillary loop. The yellow part is the mesangium. Sorry, the light gray part is the mesangium with the mesangial cell. And the small yellow thing which you see is the endothelial cell of the capillary. So basically, this is kind of a blown up version of a small part of the glomerulus. So now what happens is the food processes basically prevent protein from leaking. Now if you look at the figure on your right side, the podocytes are extremely gone. They are disarrayed. Look at the green on the left side versus the green on the right side. The green on the left side is so cutely arranged. It's like a foot. It's like so many small feet are arranged over there. But when you look at the right side, those food processes are damaged. It becomes leaky. And what happens is all the protein starts leaking into those capillaries and subsequently into the urine, causing more and more damage. So obviously in medicine, nothing is simple. It keeps adding on and on. Knowledge is never static. So basically, any diabetic also has high blood pressure. They obviously have a high sugar. This leads to oxidative stress. It leads to the renin, angiotensin, and aldosterone activation. It leads to so many side effects, which basically causes inflammation in the kidney. which basically leads to further and further fibrosis and basically leads to something called as diabetic nephropathy. Now you'll ask me, so there's so many diabetics which come to us with GFR. Now you know what is GFR. GFR less than 15. And they'll be like, my kidney size looks normal. So what you have to remember is in diabetics, 90% of the times the kidney size will actually look normal, but they may actually be in the end stage of the kidney disease. Now, how does the kidney look in diabetics? Now, for those of you who have finished your pathology rotation, you see some very classical findings in the microscopic part of the kidney. Now, can you see my cursor?
Yes, ma'am. It's
Yeah.
visible.
So these nodules, these pinkish parts which you see are the Kimmelstein-Wilson's nodules. This is actually the glomerulus. This is the real glomerulus from one of my patients. And you can actually see how these nodules have actually kind of engulfed that area where the filtration is fairly low. The capillary loops are not patent. If you can see these white areas, these are your beautiful capillaries which are surrounded by the mesangium, these pink parts. And the mesangium also gets expanded, and slowly these KW lesions may form. These are your vessels. So the arteriole, the renal arterioles again get hyalinized, which is again seen here. And you can have something called as fibrin caps, which are present. This is again a glomerulus, which is fairly destroyed here. It should, as I showed you, it should, this is how a almost a normal glomerulus looks like, but this is completely kind of destroyed in diabetes. So some of the lesions, just to recap, which you will see in diabetes are the Kimmelstein-Wilson nodules, mesangial expansion. There will be glomerular basement membrane thickening. There can be renal arteriolar hyalinosis, and you can see fibrin caps in it. So what happens is basically as the hyperglycemia continues and continues, slowly and slowly the kidney keeps getting destroyed, and at one point of time your GFR starts decreasing. So initially what happens is your kidney will hyperfiltrate, then the protein will start leaking, and then the GFR starts declining. At which point it is very difficult to manage diabetics actually because they start progressing at a rapid rate. So the initial response, all of you should remember in hyperglycemia is an increase in the GFR. It is at this stage where you can actually prevent things from happening if you control the sugars. This increased pressure and flow within this capillary will damage the nephrons. And with the damage in nephrons, you can have protein leak and subsequently protein damage. Can we go on to the next question?
Yes, ma'am. So from what you said, we found out how serious is this condition, ma'am. So apart from kidney, are there any possibilities for diabetes to affect other organs and cause any complications in those organs, ma'am?
Yes, so diabetes as such can cause both microvascular, which is in the small vessels, as well as macrovascular complications. Macro vessels are the heart, for example, coronary artery disease, stroke, that is your cerebral vessels, as well as peripheral vascular disease. So many of our diabetics suffer with gangrene and peripheral vascular disease. Now, these are your three main macrovascular complications. Why it is called macro? Because these vessels are slightly bigger. The microvascular complications mainly are the nephropathy, that is your kidney, because the kidney has small vessels going, I mean, basically the glomerular capillaries are so small. Then you have the retinopathy where the eye has very small vessels again, which is again a microvascular complication. And then you have neuropathy, that is your nerves, which again are supplied by very small blood vessels, and therefore they are called as microvascular complications. So macrovascular is heart, brain, and the peripheral vascular disease. And your microvascular is the retina, your neuron, your nerves, as well as your kidney, obviously.
Thank you, ma'am. So we now it's not a particular disease to an organ, it is a systemic disease. That is what you're saying.
Exactly. So it's a systemic disease and a systemic inflammatory response. See, in the past, long ago, when not too long ago, when we were doing the MBBS, we were not taught that diabetes is an inflammatory disease. With a lot of research which has been done, it's fairly well established. It causes so much of inflammation in the body and basically affects almost every organ in the body.
Could you please say a few more words about inflammation? We have not heard that diabetes causes inflammation. Please, could you elaborate?
Well, so if you look at my slide on these various things which happen in diabetes,
Yes, ma'am. Yes.
okay, so if you can look, this is a very simplified diagram that I have chosen to teach you with. But basically, what diabetes does is it basically kind of stimulates hyperglycemia, that is the sugar, stimulates a whole lot of inflammatory responses. So, a lot of studies have been done. So, some of the markers of inflammation include ESR, CRP, etc., which can be elevated in diabetics. So what it does is AGE is basically advanced glycation end products. It causes oxidative stress. So these issues basically kind of trigger the inflammatory response, and this inflammation is what. So whenever there is an inflammation, the next thing which happens pathologically is a fibrosis. That is, those things get scarred or those things get damaged, and that is how diabetes basically damages any organ. So to a large extent, diabetes is actually it's an inflammatory disease because it basically triggers a whole lot of inflammatory pathways.
Thank you, ma'am. Thank you so much. Because I think inflammatory part of diabetes is not been said by so many doctors, but it is very essential to know that.
Yes.
Yes. Ma'am, so moving on to the next question, ma'am. How does a person know that he is having a diabetic kidney disease, ma'am? Like, what are the common symptoms with which patients come to you with a complaint of diabetic kidney disease?
Good question. So first, let me tell you who are at risk for developing a diabetic kidney disease. So,
Sure.
firstly, the type 1 diabetics form lesser number of people than type 2 diabetics. Okay. So, most of the diabetics we see are type 2 diabetes. And what you have to remember with type 2 diabetics are that they never find out very early that they are diabetic. In one routine test in their office or in a routine test because they just decided to take a test, they may realize they are diabetic. And at that point, nobody realizes that they have to actually check their kidney function, which means we don't know for how long they're having diabetes, actually, type 2 diabetics. Whereas type 1 diabetics occurs early on. That is, young people have diabetes, children may have diabetes. So these are your type 1 diabetics, where it is fairly very obvious from early on that someone has diabetes. So it is very important that anybody you have detected with type 2 diabetes, you have to start checking the kidney then and there itself, because we don't know for how long these people have been there. Similarly, older people who present with diabetes, men are supposedly slightly at higher risk. Indians, Africans are more at risk of developing diabetic kidney disease. If you have a family history of kidney disease due to diabetes, it is possible that we can have it. If it is compounded by being obese, having high blood pressure, if you are smoking, if you are taking all sorts of unnecessary medications, and you unnecessarily stress your body for no reason, these again add to the risk. If you are a diabetic, it adds to the risk of diabetic kidney disease. So it's very important to understand these risk factors, because by cutting down on the other risk factors, you actually kind of can prevent somebody from progressing further and further. I will come back to this slide a little later. Before that, since you had asked me about the question on whether it affects other things, please
Yes, ma'am.
remember that the diabetes and the eye always have a connection, because both have a microvascular structure. If you look at this, this is your normal retina on your left side, and look at the eye in diabetic retinopathy, full of hemorrhages, and basically it affects the eye in so many aspects. And if somebody has retinopathy, it's fairly sure that they will be having some amount of nephropathy. And similarly, when you detect somebody with diabetes, not only do you check the kidney, you also have to check the eye on a regular basis because it can lead to severe complications. So, so diabetes is the most likely cause of the kidney disease. If the patient is having albumin in the urine, if somebody is having concurrent diabetic retinopathy, and the patient is having a long-standing diabetes, I again emphasize, if you have diagnosed somebody with type 2 diabetes, please make sure that 10 years, maybe 10 years, we never know for how long they have been suffering. So it is always important to check the kidney function at the onset of the diagnosis.
Thank you, ma'am. Ma'am, so the next question is, if a person is a non-diabetic person,
Yeah.
so will you advise a person to go and test himself for diabetes? Are there any criteria like after this age, or if you are having these things, it's better you check for diabetes? Do
Yeah.
you advise people like that?
Yeah, exactly. So yes, I would suggest anybody after the age of 40 to keep a watch on their sugars, because with the all the junk food that everybody eats nowadays, with the amount of salt intake and with the amount of sugar intake, diabetes has become like an epidemic right now. If you notice, our grandparents or great grandparents, for example, hardly the diabetic load was very low because the way they used to eat and their lifestyles were really good. But now, when you see younger and younger people are developing diabetes mainly as a part of something called as metabolic syndrome. So, anybody who's obese, who is a smoker, who has a family history of diabetes, who has symptoms like polyphagia, polyuria, etc., it's always good to get tested for sugar because early control of sugar has been really made a difference to not developing diabetes related complications.
Yes, ma'am. Ma'am, so the next question is about what are the principal managements, ma'am? So we have found a person having diabetic kidney disease. So what are the first line and the second line treatment that a doctor would offer to that patient?
Okay, so before that, any diabetic, we have to make sure we do a serum creatinine. I think I've emphasized this enough. Do a urine analysis, if possible, a urine protein evaluation, and of course, evaluate them for the other causes or other complications due to diabetes. Because you have to remember, it is like a conundrum. You have diabetes, you have kidney disease, it is possible you have a retinopathy, it is possible you have significant cardiovascular disease, and it's really possible that the patient has other complications related to diabetes. Basically, it is that it is a systemic disease. So, if you have found out one complication, it's really possible that the person has the other diabetes related complications. So, check for all that. And at every visit that a normal diabetic is making, please make sure you get a urine analysis done. Please make sure you see the creatinine and just not see the creatinine alone. Actually calculate the GFR and see what is the reason why this particular patient is basically improving or worsening. And if worsening, please refer to the nephrologist because a lot can be done at an early stage. Because what we generally end up seeing is at a very late stage where we don't have many options to actually reverse the process. And also, please get other tests done. For example, an ultrasound, as I told you, other things like a complete blood count, lipids, because that again is a risk factor for cardiovascular disease. A1C, also called as the HbA1c or the glycosylated hemoglobin, which again can cause issues, and additional tests as prescribed by the physician or the nephrologist. So, based on this, one of the most important things is the glycemic control initially. So, keeping an A1C less than 7% is extremely good. It helps us prevent getting the other complications of diabetes. A blood pressure control, again, very important. As you know, what do you mean? The diabetes basically affects the glomerulus. If the blood pressure is very high, the amount of pressure on the glomerulus is much more, and your proteinuria may increase. So your BP goals should be less than 130 over 80, rather 120 over 80 is what I would suggest. Um,
Ma'am, screen is blank, ma'am.
can you see now?
No,
Ma'am,
no,
it's
ma'am.
Normal.
black. Not to you.
Can you see
It
one
is
second?
blank, ma'am. It's showing black screen.
Can you see now treatment principles?
No, ma'am.
1 minute.
Sure.
So basically, I will talk while I fix this.
Yeah, ma'am.
So
It's
basically,
showing.
sugar
It's
control.
visible now.
It's visible now.
Yes, ma'am, it's
Yes, ma'am.
visible.
It's visible.
I can't see. Can you see now?
No, ma'am.
No, ma'am.
Now?
Yeah, yeah,
Yes,
yeah,
ma'am,
ma'am.
it's visible.
Right, yeah. So coming to the treatment principles, the most important thing is the sugar control. And one of the things for the sugar control is your keeping your HbA1c less than 7%. Basically keeping your sugars under a good control, taking your blood pressure at a very, very good control. Always, as I told you, always assess for the other risk factors like a cardiovascular risk factors. If somebody's cholesterol is very high, treat it. If somebody is smoking, tell them to stop smoking. Obesity, high risk factor for getting diabetic related complications, cardiovascular complications, stroke, you name it. Obesity is a result, is a risk factor for that. So basically advise them good physical activity and a good weight management. The other is if somebody has developed proteinuria or albuminuria, we try to reduce the albuminuria. These are done by two important agents as of now. One is the renin angiotensin aldosterone antagonist, which forms a group of drugs called as ACE inhibitors and angiotensin receptor blockers, also called as ARBs, and also the other group of drugs which are probably a golden opportunity in diabetes, which I would call in the recent years, is something called as SGLT2 inhibitors, which I do want to kind of give you a small kind of introduction on, so that you will have an edge over knowing about these when you treat such patients in the future. Avoid any sort of unnecessary drugs. Many people say, okay, let me take Siddha therapy, let me do this. Well, all those are not proven therapies. It is better to avoid any drugs unnecessarily, because most of the drugs can damage the kidney. Try to kind of switch to a plant-based diet if you have already been diagnosed with diabetic kidney disease. Try to lower your animal protein intake to some extent. And this, I'm not going to delve much into detail because it is a topic of its own. A salt reduction, very important, because it is one of the most important things to control the blood pressure. So salt intake should be reduced to around 5 grams of per day if your doctor has advised you to. Moving on to something called as RAS blockade, one of the therapies which have been proven to reduce the diabetes from progressing from one stage to another is your renin angiotensin aldosterone blockade. Now, my screen is visible.
Yes, ma'am.
Yeah, ma'am.
Yes,
It's
ma'am. Yes,
visible.
ma'am.
So if you know, this angiotensinogen gets converted by renin into angiotensin 1, then you have your ACE enzyme which converts in the lung, which converts angiotensin 1 to angiotensin 2, and angiotensin 2 then goes and attacks the AT1 and AT2 receptors in order to produce aldosterone, which is again kind of acting on your mineralocorticoid receptors, also called as aldosterone receptors. So basically, this entire pathway has been implicated as a bad pathway in increasing the pressure inside the glomerulus in the kidney. So what happens is when we use something called as ACE inhibitor, it basically inhibits your angiotensin converting enzyme and prevents the angiotensin 1 from getting converted into angiotensin 2 and the subsequent pathways. And when we use an angiotensin receptor blocker, it will block the angiotensin 1 so that AT1 receptor, so that it does not go further into aldosterone and aldosterone receptors. Now, what happens is these are all responsible both for systemic as well as glomerular hypertension, which is what we want to reduce basically. So in a normal glomerulus, what happens is, if you look at your diagram on the right, it's a very informative diagram basically. There you have your normal glomerulus. So if you look, this is your afferent arteriole. It kind of forms a whole group of a mesh of capillaries, and out of that comes out your efferent arteriole. So the kidney is one of the organs which starts with an arteriole and ends with an arteriole. Generally, what happens? Your blood will be entering an organ through an artery and it will be leaving the organ through a vein. But whereas in a in a kidney, especially in the glomerulus, it's basically a small arteriole coming in, forming small group of capillaries, and then it is going out as a arteriole again. In diabetes, what happens? There is a dilatation of the afferent arteriole, and then you have the efferent arteriole, which is constricted. So basically, what happens is the what this angiotensin 2 receptor, like ACE inhibitors or ARBs, do is they basically decrease the pressure on the efferent arteriole. Now, if the efferent arterioles become too constricted, the pressure within the capillary system will increase and increase and increase, and therefore you will have more protein loss in the urine. Whereas what the ACE inhibitors do is they increase the efferent E for elephant, efferent arteriolar dilatation, so that the pressure in the glomerulus is reduced and hence the protein leak is reduced. The other important mechanism of this group of drugs is it reduces the systemic hypertension also, which again reduces your damage to the kidneys. So it is a very, very important group of drugs which should be used unless there are any contraindications in all patients with diabetes and diabetic related kidney diseases. Now, the other group of drugs which have caused a huge amount of, which have gained a lot of importance, because we did not have this group of drugs in the past. Now, what happens is, as I've already mentioned to you, hyperglycemia leads to an increased sugar exit through the urine. Now, most of the sugar should get kind of reabsorbed at your proximal tubule. But now, when you are a diabetic, your sugar in the blood is so high that your capacity of the tubule to kind of reabsorb the sugar is gone. So what happens? You start leaking the urine inside, leaking the sugar inside the tubule, and basically cause more and more of side effects. So what happens is, if you look at this picture, again you have the glomerulus. This is the glomerulus with the proximal tubule, the loop of Henle, and the macula densa here in between, and you have the distal tubule. So whenever there is a normal GFR and your sugar is normal, there is no issue which is happening. The tubuloglomerular feedback is intact. Whenever there is hyperfiltration in diabetes, there is an increased, so the tubule starts to kind of increase its capacity to absorb that glucose. But now what happens is, if when this starts happening, there is an afferent arteriolar dilatation in order to do this. And there is a decreased sodium delivery to the macula densa, and there is a impaired tubuloglomerular feedback. So this basically leads to all the complications which lead to diabetes. Now, when we use drugs which kind of block this increased sodium glucose reabsorption, we try to restore the tubuloglomerular feedback and basically reduces the pressure inside the glomerulus. And right now, these group of drugs called as SGLT2 inhibitors have become one of the mainstay in the management of diabetes as well as diabetic kidney disease.
Thank you, ma'am. That was really elaborate. because so many people, as you said earlier in the discussion at the starting point, diabetes and hypertension go on hand. So a person who's having diabetes invariably tends to have hypertension.
Yeah.
So so many medicines. When some medicines are commonly acting on both the systems, it
Yeah.
is very useful for the patient as well as for us. So it's very informative that you've shared this lesson. Thank you so much. So, ma'am, we have spoken about the clinical aspects of diabetic kidney disease. So, if we move little more to the practical aspect, ma'am, how much knowledge do you think that the patient who is having diabetes has about his complications? Like, does a patient know these are the things he's going to develop because of diabetes? Are they aware of all these things?
Not really, actually. Good question. And to a large extent, most of the diabetics I see hardly have any idea that their kidney is damaged. At least to some extent, cardiovascular disease, many people are aware. Like, for example, they get even a small chest pain, they will land up in an emergency and try to do an ECG. But when you look at the kidney, to a large number of people, there may not be much symptoms of kidney disease. So only when somebody goes to the end stage do they actually know that they may be having kidney disease. So what happens is there is very little awareness that diabetes actually causes so much of damage. I have seen many groups of clinics in the city which do a whole lot of tests on these people. They test the nerves, they test the heart, they test everything. But the information to the patient, or rather the communication to the patient, is fairly very low. But yes, it's very important that, and I think this sort of webinars where you guys at this level itself realize that this has to be checked will make a lot of difference when you kind of start practicing uh, in in real life.
True, ma'am. Thank you so much, ma'am. So, yes, ma'am. Again, in the early part of the discussion, you also mentioned that diabetes has immunosuppressive effect on the patient. So,
Correct.
being in a pandemic like this, ma'am. So, how vulnerable is a diabetic patient in developing COVID when you compare with a normal person, ma'am?
Well, yeah. So there is definitely an increased risk in both patients with diabetes alone, diabetes with kidney disease. Both have high risk factors. Also, many of these patients end up not many, but a group of these patients end up requiring dialysis or transplantation. So basically, all these together cause a whole lot of immunosuppressive effects, which makes them at higher risk for getting diabetes.
Yes,
Sorry,
ma'am.
higher risk
Thank
for
you.
getting COVID. Sorry.
COVID. Yes. Ma'am, another general question. There are so many drugs that are being prescribed for COVID currently. If we take the new regimen, there are almost they've included 10 drugs in that, including antibiotics, ivermectin, and then vitamin supplements. So
None
when
of
a
them are
diabetic
useful.
person is getting,
None of them
ma'am,
are useful.
sorry?
None of them are useful.
Yes, yes, ma'am, of course.
Yeah.
That is another different thing. So when a diabetic person is getting COVID and when he is being prescribed such a huge lot of drugs, is it safe for that person to take both an anti-diabetic drug and these set of drugs for
But
COVID, ma'am?
I would,
How?
that's exactly what I'm saying. Don't prescribe these drugs. It's not useful. So the only thing which is useful in COVID is one, masking. The other is once they have been diagnosed with COVID, they have to continue their sugar medication. Sugar control is extremely important when somebody has a viral infection because the sugar can go either very high or very low. So it is important to monitor the sugar, monitor their saturation as every other person has been asked to do, and report to the hospital if their saturation is low. So there is no role for any of these vitamins and all these antibiotics, ivermectin, another one which has no basis, scientific basis at all. So I personally see a lot of sick COVID patients. I have not prescribed any of these to any of them. They are fairly done okay.
Yes, that's really true because half people don't know that an antibiotic doesn't work for a virus.
Exactly, exactly.
So there is lack of awareness that people usually have.
Yeah.
And recently, we are getting news about these 2 glucose, 2D glucose that is being prescribed for COVID. Ma'am, so when a diabetic patient already has hyperglycemia, how
Yeah.
safe is it for him to take this 2-deoxy glucose? Will it alter his glycemic index? Will it actually increase his sugar levels?
Good question. Well, I think it has not yet been launched, if I am not wrong.
Yes, ma'am. It has not been launched. It is
It has
under
not yet
trials.
been launched, is what I understand. But so basically, I don't. Yeah, it does actually inhibit the G6P, that is glucose 6 phosphate. Yes, it may have some effect on the glycemic control. Good question.
Yes,
Again,
ma'am.
I
Which
don't
means,
know how much of scientific data is available on the 2DG. I know the
yes,
ICMR or the DRDO are planning to kind of launch it probably next week or something like
yes, ma'am. So then the last question from our side today is this one. So when a patient, when a diabetic person is getting vaccinated, is there any problem for him to develop any complications, ma'am, or is it safe for a diabetic patient to get COVID vaccine?
yeah, it's very safe for any diabetic to get the COVID vaccination. I know that there have been a lot of sort of concerns that it itself, so there are a few things I have heard. One is that the vaccination itself can cause COVID, which again is fairly baseless because both the vaccines we currently have, one is the Covishield, only uses the spike protein and not the whole virus itself. And the other one, which is your Covaxin, is a killed vaccine, again, which cannot replicate in the body. So both of it cannot cause COVID on its own. The other issue I've heard is a diabetic cannot take it because they can develop a heart attack, especially after actor Vivek died. I think it has been a real difficult thing for all of us to convince our patients to take the vaccine actually. To be very clear,
Yes,
that was not related to the vaccine. He had a coronary artery block which cannot develop over a couple of hours. So yeah, it is fairly safe. I think the only contraindication to take the vaccine as of now is anaphylaxis, which is if you have a severe allergic reaction to the vaccine.
thank you so much, ma'am, for this awareness because so many conspiracies have been developing on vaccine. But at this point, vaccination is the only thing that we all see as a ray of hope.
Yeah,
So thank you. At least after listening to your words, I think the audience will advise their parents and their family members to get vaccinated.
hopefully.
Um, so that's the thing. So we've almost come to the end of the session. Now it's time for the audience for asking your questions. You can put it either in your chat box or you can text us. So, ma'am, before the audience asks question, I have a personal question. Um, I don't know whether this actually sounds really logical, ma'am, but the thing is, when a diabetic person is having more sugar, what is wrong in sugar, glucose getting eliminated out of the body? Why is glycosuria or glucosuria treated as a bad thing for a diabetic person? He's excreting
Because
sugar, which should get low.
correct. So what it is doing is it is causing a hyperfiltration. So now your glomerulus is only supposed to, it's basically kind of programmed to eliminate this much of glucose. Now if that glucose keeps on increasing for it to, you're overloading the glomerulus basically. You're overloading your filters with so much of glucose. Now what happens? Also the kidney is a lovely auto-regulatory organ. So whatever you do to it, to some extent, it can auto-regulate to an extent that okay, it can keep up to the normalcy. Now when you exceed that, even the extra normal limit, damage starts to happen.
Yes, ma'am. Thank you so much, ma'am. Ma'am, so we've discussed about practical knowledge and theoretical knowledge of diabetic kidney disease. So could you please illustrate it with a case so that all of us would better understand, like how the patient comes to a doctor and how it should be managed?
Well, I put up a few examples if that helps.
Yes, ma'am.
We have so many different types of presentations. So for your understanding, this is a 65-year-old man with diabetes for type 2 diabetes. So from 45 years of age, he's been having diabetes, and he also has diabetic retinopathy. Now he has got a protein leak in his urine, and if you look at his glomerular filtration rate, it has gone down from 66 to 10. So basically, it is really low. So this group of patients we see very, very often because most of them kind of get referred to us at a fairly later stage, like a GFR of 10. So this guy may have diabetic kidney disease because he has a long-term diabetes. He has got concurrent retinopathy, which again is like a window to the kidney. He's got protein leak in the urine and he has a low GFR. So this is somebody who could have diabetic kidney disease. Now, this was a lady who came. She was a 69-year-old. She has diabetes for 15 years without any retinopathy, and she's been diagnosed with SLE for the past 4 to 5 years. Now, she has almost no proteinuria, but her GFR is slightly on the lower side. Now, can she have diabetic nephropathy? Probably not, but it is not for certain. So such patients who we don't know or we don't have a clear-cut idea, we generally do a kidney biopsy to see whether they have changes of diabetes. That like the way I described those chemistry and Vincent nodules and all that.
Yes.
Now, this is a 28-year-old woman who came with type 1 diabetes for 9 years and has retinopathy for 4 years. Now she has again got proteinuria, and so basically, this lady actually came to my clinic yesterday. Her GFR has been declining slowly. So this lady probably has diabetic nephropathy because she has had type 1 diabetes. So if you remember, type 2 diabetics can have kidney disease at presentation itself, whereas type 1 diabetics, when you look at the progression of kidney disease, can develop it after 8 to 10 years. So this lady has had a fair amount of type 1 diabetes and now she has presented with kidney disease. Most probably it is due to diabetes. Okay, so these are the things. So you try to see whether it is a type 1 diabetic or a type 2 diabetic, whether they have other
Yes.
complications due to diabetes, and please check the creatinine, do an ultrasound as well as the urinary protein in order to see whether the patient has kidney disease.
Yes. So one person from the audience has asked you that is it safe to prescribe corticosteroids and dexamethasone in case of a COVID positive diabetic patient?
Yeah, so this depends on one whether they really need it or not. Now, the mainstay of COVID treatment at present is giving steroids only when the patient needs it. I emphasize only when the patient needs it. That is when they have a low saturation or when they have significant lung involvement. There is no need to give dexamethasone for anybody and everybody diagnosed with corona. So most of them are actually asymptomatic or have mild symptoms like a running nose, which you would have temporarily ignored if you did not know about corona actually. So it's do you use steroids in those cases? No. So that is the same thing which holds. So steroids are used only when there is significant lung involvement and significant low saturation. At which time the sugars have to be monitored very, very carefully because we have a huge corona ward full of COVID patients. All of them have deranged sugars, and it is a high risk for fungal infections. And there are more and more case reports of fungal infections which are killing people after
Yes.
overuse or indiscriminate use of steroids.
Yes. That is very important. Judicial usage of drugs. That
Yeah,
is what you're
and
meaning.
for actual indicated cases. There are so many areas where we are seeing because people are using these steroids so indiscriminately. We are not
Yes.
actually getting to get the steroids to the people who need it.
Yes. So that is very important point you've told us. Thank you so much for that. Another person has asked, can diabetic patients develop electrolyte imbalances which are related to kidney damage?
Very good question. Yes, they can. Many of the diabetics can have high potassium because many of them have something called as renal tubular acidosis, which is a type 4. So they can have acidosis, they can have hyperkalemia. If the sugar is very high, they can have pseudo hyponatremia. They have a very deranged vitamin D axis in later stages of diabetic kidney disease, so they can have a lower calcium and phosphorus. And as kidney disease progresses, the electrolytes can get more deranged.
Thank you, ma'am. Ma'am, another person has asked, how can a common man know that there are symptoms of diabetic or kidney failure without any routine blood and urine test?
Well, a routine, yeah. So very, if you look at it, many of the patients may not present with overt signs of kidney disease. Some people can present with swelling in their legs. They may have uncontrolled hypertension. One of important clue is that somebody who has very uncontrolled sugars starts to have lower sugars. That means that the kidney may not be working because the insulin as well as the gluconeogenesis. I don't know whether many of you know there is a certain amount of gluconeogenesis which happens in the kidney, and the insulin metabolism happens with the kidney. So many of these patients will have higher insulin levels in their blood, which they can go into recurrent low sugars. This is one of the clues which can be there. They can have extreme fatigue, which is more than the normal. They can have anemia, which is low hemoglobin, because the kidney is responsible for the production of erythropoietin. Yeah, so these are the things which can kind of happen when somebody has this one kidney disease. But
Again,
yes,
one fact we
don't
learned from
worry,
your
they
question.
may have other signs. Once they've reached end stage, they can have itching, they can have vomiting, they may not be able to eat, and so on and so forth.
Yes, ma'am, you told us another new fact. I think this session is full of new facts for me. You've told gluconeogenesis and regulation of insulin happens in kidney. I don't think many textbooks talk about it.
Yeah,
Thank you for that.
I think I
Ma'am,
can.
another question.
Yeah.
Does intermittent fasting help control diabetes?
Well, yeah. So, good question. So, the latest papers on intermittent fasting is yes, it does reduce body weight to some extent, and to some extent has a good effect on the metabolic parameters. So, you should understand it's like a conundrum. It's just not the diabetes alone which is getting controlled. You lose weight, you are going to control your diabetes. But there are some confounding papers again which says that it may not be very useful because it is very difficult to follow an intermittent fasting diet for a very long period of time. Because, like for example, we work for so many hours, right? Like it's very difficult to fast.
Yes, ma'am.
So, a balanced diet, a Mediterranean diet, has a far more better effect on controlling diabetes rather than just doing intermittent fasting. So good physical activity as recommended by the WHO, 3 to 4 times a week of good cardiovascular exercise, as well as this one is supposed to have a better effect than just doing intermittent fasting alone.
Yes, ma'am. And the last question. If patients keep their blood sugar levels normal, I
Hmm.
think he's meaning diabetic people, will they develop kidney disease?
Sorry, I didn't get the question.
If patients maintain their blood sugar levels normal,
Yeah.
can they develop CKD?
Well, if you control your blood sugars well early, there are good scientific papers which show that you may prevent the progression or developing kidney disease. However, it just does not, as I told you, it is just not one pathophysiological mechanism. There are so many other factors which can also influence. So I wouldn't say it. See, nothing in medicine is 100%. You do this and 100% you won't develop this. So it is not like that. But yes, to a large extent, you can control it from going further. So you should
Yes,
remember
ma'am.
that out of 100 diabetics, around 30 to 40 diabetics can develop kidney disease. So if you see 100 diabetics on the road, almost 40 of them may be having various stages of kidney disease.
You say it is inevitable for a person to develop any
Some of
complication if they
it is
have diabetes.
inevitable, some of it is inevitable, but some of it is purely preventable. A diabetic continues smoking, nobody can help him. He is going to develop peripheral vascular disease, he is going to develop retinopathy, he is going to probably develop nephropathy.
Yes, ma'am. So, what are the do's and don'ts that a diabetic person shouldn't? I mean, what are the things he should not do? He should completely refrain himself from. like smoking, alcoholism,
Yeah.
anything else in particular?
Stop smoking, reduce your weight, good physical activity. Don't take any unnecessary drugs. Very, very important because control your blood pressure. It has to be done. So diabetics should check their blood pressure every month. Reduce salt, which again causes a lot of. Keep a good healthy lifestyle is extremely important for any diabetic, especially when you develop diabetes at a younger age, right? Somebody at a 40 developing, you have more number of years in front of you. So the longer you have diabetes, you have more the risk of complications related to it. So that's why you need to kind of do that.
Thank you so much for your patient answer. So almost we've come to the end of the session. So the viewers, please do fill in the feedback form. So now today we have Dr. Rajeevalochana ma'am with us, who told us in and out of diabetes and diabetic kidney disease. So on behalf of professional health team, we wholeheartedly thank ma'am for her valuable time and for accepting our invite for this session, and for all pragmatic replies ma'am gave, because nothing was actually implied. Ma'am, whatever ma'am said was actually practical. So we thank you ma'am for this practical session of discussion. And we would also like to thank all the audience for your enthusiastic involvement and all the nice questions you've put up in the chat box. Thank you for your time. And we will meet you soon with another interesting topic and another interesting person. So until then, please stay indoors and help people who are in support, because at this stage, people just need moral support. So please do give that. But stay safe, first safeguard yourself. Thank you all once again. And thank you so much, ma'am. Thank you. Thanks a lot.
Lovely